Hello, I'm Dr. Megan Mello. I'm a family and obesity medicine physician, and I'm here today to talk about some of the insurance challenges that come up with some of our popular anti-obesity medications, including Wegovy, diabetes version of that is Ozempic, and Zepbound, diabetes version of that is Mounjaro. So you may hear these medications talked about by any of those names. One of the major challenges that is not well discussed in all the media buzz about these medications is about the insurance coverage. People will often come into my office looking for these medications and they'll say, I have great insurance, I'm sure it will be covered. But when they call to check or when we send a prescription, they find out it's not covered. Why is this? It turns out for our anti-obesity medications that it has to do with what Congress put into the requirements regarding health insurance. So health insurance is required in the United States by law to cover certain conditions. It's required to cover things like diabetes and high blood pressure. It's required to cover things like well baby visits and well child and preventative exams and prenatal care and cancer treatments. Now, the degree to which those things is covered is variable across insurances, but they have to have some coverage in place for all of those usual conditions that come up. With special areas of medicine, including obesity, including fertility, these things have been left out of regular health insurance requirements. That is, the insurance companies rather, are not required to put these things into the insurance coverage packages that are most commonly being brought to the employers, right? In the United States, with the exception of Medicare and Medicaid and the private health insurance exchanges that are available through the Affordable Care Act, most people receive their insurance coverage from their employer, right? From their job or the job of a spouse or a parent. The employers decide what plans they choose to incorporate and offer to their employees. And they have the option of adding in coverage for things like fertility treatments or obesity medications or bariatric surgeries, right? Some of these specialized areas in medicine that are not required by law to be a part of the regular insurance packages. So then what happens, right? We have absolutely some employers, and it's growing over time, who have opted in to add this coverage into their plans. They have decided that fertility treatments or anti-obesity medications or bariatric surgery are important for the health of their employees, and they have chosen to pay for them. Again, the degree to which they pay for these things is variable. Some people have very low copays, some have very high copays, but many employers have not chosen to add this coverage in for their employees. And if they have not opted in to pay extra for this special coverage, then these medications or bariatric surgery or, again, fertility treatments are not included in the insurance plans. And this is one of the major hangups when it comes to using insurance to pay for anti-obesity medications. Now, what I see happening over, the next several years, and hopefully sooner rather than later, is that we realize that obesity and metabolic health are really key, and that early intervention, early prevention, early treatment of these issues really helps to, prevent the more serious health consequences, right? If we are treating risk factors for diabetes, including insulin resistance, including prediabetes, if we are preventing people from getting diabetes, we will not only prevent them from getting the health complications that are associated with diabetes itself, we will also see lower rates of heart disease and cancer. And, we will see lower costs overall. But again, right now, insurance has to cover diabetes, and they do not have to cover risk factors for diabetes. They do not have to cover medications to treat insulin resistance, prediabetes, family history of diabetes. Those things are not included in the coverage for diabetes. So one thing that needs to happen, as I said, is that Congress needs to decide to put anti-obesity treatments, right, including medications and surgery, into what is required to be covered by your insurance. So that is one step. Another step is that employers, maybe need to step up and decide that treating obesity and treating metabolic health in their employees makes a huge difference on, the health and quality of life of their employees, and they want to decide to help cover it. Although it would be nice if these health conditions were not severe, not significant, not so prevalent. We know that obesity and metabolic health are major, major health conditions in the United States and in other places in the world. And that if we treat people early, right, if we prevent these more chronic and severe complications from occurring, right, we will improve the health and the productivity and the lifespan and what's called the health span. That is, the expanding of the duration of healthy, active, productive years of life compared to years of life that are spent, diseased and disabled and immobile. We want to really help those things. But again, right now, employers need to make that decision, right, to help pay for it. If you do not have insurance coverage for these medications, it doesn't necessarily mean that there's no treatments available to help obesity and metabolic health. Certainly, I have some patients who are able to decide to afford these medications, or certainly we know that people will pay out of pocket for bariatric surgery, both in the United States and by traveling to other places where these procedures are commonly done. That is obviously not going to be in the budget for many, many people. If we're looking at our anti-obesity medications, our popular GLP-1 medications, again, including Wegovy, which is the weight loss version of Ozempic, or Zepbound, the weight loss version of Mounjaro, these medications can easily cost over $1,000 a month, right? That is obviously going to be out of reach for many people. But sometimes people have chosen to work this into their budget and decide that it is a priority for them because they are able to do that and their health is paramount to them. If we've gone through that route, if you're not able to afford to pay cash for these medications, as many people are not, sometimes we can appeal the decision. Sometimes we can write specifically to the HR department and ask for an exception, right? Ask for special coverage for these medications. That, can help sometimes. Sometimes the employer will decide, yes, we will agree to pay for these medications for this person. We will add an exception, a rider into their health coverage. It does happen some of the time. I can't say exactly how often it happens, but it does happen some of the time. Usually it does not work to appeal the decision from the healthcare company unless something has been put in incorrectly in the prior authorization. And that does happen a fair amount of the time. So it's always worth looking at what are the reasons they said that the prior authorization was denied. Was it denied because we did not include the specific BMI number, right? If we just need to make sure that that number is very visible, that can be something that makes or breaks the decision. So it's important to review the prior authorization denial and see what the reason was, make sure that the documentation was correct. It's also important that when the prior authorization, which is always required for these medications, whether or not they're covered, when it goes in, that it includes the highest BMI for that patient. There's a lot of concerns about BMI as a number, and I get that, and I endorse that, and I talk to all my patients about, the racist origins of BMI. It is a problematic number, but it is still the language that we use to communicate with your insurance company when we are looking at these medications. But if the BMI number that is being used to request these medications is a lower BMI than the highest BMI, then these medications will often be denied. So let me give you an example of this. Perhaps somebody was put on Ozempic several years ago. They were able to successfully lose 50 or 60 pounds. They started with a BMI of 31, and now they are at a BMI of 26. BMI of 31 is considered obese and often qualifies for treatment. A BMI of 26 no longer qualifies for treatment. However, we are still treating the higher BMI because the tendency of the body is to regain the weight. That's an important thing to consider when we're using these medications. We will not adjust the BMI as it goes down, but many physicians and healthcare providers are not aware of this. We need to continue to use the highest BMI that the patient has had, because that is what justifies the ongoing treatment. These are considered long-term treatments. What the science shows us is that people need to continue these medications. Otherwise, they will have weight regain the majority of the time. And thus we are still treating that highest BMI and not the lower BMI that they are coming in maintenance. So I hope that gives us some ideas of what's going on when insurance denies. It's a complicated issue because, again, we are dealing with a very important, health situation, right? When we've got obesity plus or minus metabolic disorder, we've got this important, sort of precursor state to so many other health conditions, but it itself doesn't often qualify for treatment unless the employer has opted in. So again, we need to advocate at the level of Congress to include obesity as something that is worthwhile of treatment, independent of, chronic disease conditions, including diabetes, heart disease, high blood pressure. We need to make obesity worth treating, right? We need to get that into regular health insurance. For the time being, we also need to advocate that employers are covering these treatments for their employees. They are expensive, but they do help to significantly reduce chronic disease burden, to improve quality of life and health. And, we ought to have more coverage for them than we do. And then for an individual, if you are denied, it's worth really looking at the prior authorization denial, seeing if anything needs to be tweaked there, seeing if there's any avenues to getting the medication coverage. And then again, asking the Human Resources Department, the benefits coordinator, whether or not somebody might make an exception for an individual to have coverage for those medications. So that is some of the steps that are involved with this process. I hope that gives you some more information about why the coverage is so variable for these very important medications. And appreciate you watching. Thanks.